Hi, I am Mafe Roa. I am part of the Center for Research and Formation in Artificial Intelligence at Universidad de los Andes. This work was developed with Laura Daza, Maria Escobar, and Ángela Castillo, advised by Paula Arbeláez. Our work is titled SAMA, Spatially Aware Multimodal Network with Attention for Early Lung Cancer Diagnosis. One of every four cancer-related deaths are caused by lung cancer. However, 35% of nodules are not detected in initial diagnosis, since they are hard to detect. Therefore, lung cancer diagnosis requires very experienced specialists. Lung cancer can be classified in different stages according to the spread of the cancer. In early stages, it is only found inside the lung or nearby lymph nodes. In later stages, it spreads to both lungs, surrounding areas, and even distant organs. The chance of successful treatment is highly related with the stage cancer is diagnosed. The earlier it is diagnosed, the higher chances of survival. Unfortunately, usually cancer is diagnosed in the fourth stage. This motivates us to deepen in the research for more precise method to early diagnose lung cancer. For a traditional diagnostic process, a doctor considers information from the patient's medical history, such as family cancer history and comorbidities. Additionally, the specialist will consider characteristics of the patient, such as their habits or whether they are a smoker or not. Based on this information, the specialist will analyze the medical images, like CT scans, and pay more attention to specific anatomical locations, such as where nodules are usually found. However, most computer-aided diagnosis methods for lung cancer diagnosis do not consider the anatomical spatial relationship between images and patient's information. In a usual clinical context, if we take all the available chest CT scans, there is high imbalance of lung cancer diagnosed patients, and there are hard negative samples, which means that there will be patients with risk factors and even non-cancerous lung lesions that would increase the difficulty of having good performance on a computer-aided diagnosis method trained in a realistic dataset. Most of the available datasets for lung cancer diagnosis don't have a realistic imbalance and only contain visual information. Notwithstanding that specialists use multimodal information in their clinical practice to perform better diagnosis. Handling information from diverse sources is closer to the way humans process information and learn from it. In a non-clinical context, visual and language information is related to object location in video tracking. Dynamic filters were originally proposed for this task, as shown in the figure, where frame by frame, visual information is used along with language information. Dynamic filters are specific visual filters for each target that are specialized and adjusted based on the language input of the network. Taking this into account, we present SAMA, a method that merges visual, clinical, and spatial information to produce more refined predictions, taking advantage of the multimodal data available and resembling what a radiologist would do. SAMA processes information in two parallel branches, one for each modality of data available. We process the two branches output using our SAMA module that merges the information using mechanisms of channel and spatially aware attention. The final representation goes through a multilayer perceptron to generate a single lung cancer prediction. Our SAMA module is divided into components that add spatial and channel attention. In the spatially aware attention component, we generate dynamic filters that change according to the patient's clinical information using a dynamic convolutional layer. Then, we generate a 3D spatial cartoon representation of the visual information, and we concatenate it to the CT scan. This concatenation is filtered with the dynamic filters to produce a response map that joins spatial and visual information. The second component is the fusion with channel attention. First, we concatenate the generated response map, the visual, spatial, and clinical information. This goes through a squeeze and excitation channel attention mechanism. Finally, we pass this weighted concatenation through a pointwise convolution to reduce dimensionality and summarize the information. The output of the SAMA block is passed through a multilayer perceptron, and the model outputs a prediction of lung cancer. We use the recently proposed LUCAS dataset, the first that contains visual and clinical information for lung cancer classification. This dataset contains information for 830 patients with only 72 samples for lung cancer. For each CT scan, it has an associated biomarker vector that represents the clinical information available. The biomarkers have, for example, information about a lung nodule located in the superior left or right lobe, and the information about other pathological findings in the images. This dataset also proposed a baseline method that is the state of the art. We compare our performance with Lucas, the state-of-the-art model for this dataset. We can see that SAMA manages to surpass the state-of-the-art by 14.3% for F1 and 16% for AP. In the following table, we can see the results of the experiments carried out to verify the complementarity of the visual and clinical information. In the first row, we can see the results of training only with the visual branch. The second row shows the results of training the model only considering the clinical branch. Finally, the last row shows the results of training using multimodal information with our SAMA model. Here we can show that the performance of the model improves when using multimodal data with SAMA, which verifies the complementary nature of the modalities. To check the relevance of each of the SAMA components, we performed a series of ablation experiments. The first table shows the effect on the performance of the model of removing the dynamic filters and the squeeze and excite. We can show that removing any of these components shows a reduction in the performance of the model. In the case of dynamic filters, this reduction may be due to the fact that the dynamic filters function as a spatial attention mechanism that relates visual information to specific anatomical location described in clinical data. On the other hand, in the case of the squeeze and excite block, this block allows our model to focus on the most relevant features regarding the channels. The performance reduction produced by removing either component is comparable. Then, both components are crucial to the overall performance of the model and complement each other. The second table shows the results for the experiments that allow to verify the relevance of the spatial representation of visual information and its complementarity with dynamic filters. In this case, it is evident that using the spatial coordinate representation only, as well as using the dynamic filters without taking into account this representation, reduces the performance of the model. This shows that both components must be present to take full advantage of the inherent spatial relationship between visual and clinical information. The set of these components associates with the clinical description to a specific location in the volume, supporting the spatial attention mechanism. Now we show qualitative results to empirically illustrate the spatial attention of dynamic filters. These results show an unsupervised intermediate representation where the response of the dynamic filter is related to the location specification present in the clinical information, showing the nature of adaptation and specialization of the dynamic filters to a given language input, leveraged in the representation of a spatial location. This figure shows the results for a patient diagnosed with tree in bud. This pathology is visually identified as branches of a tree as seen in the image. Here we can show that despite not having annotations that indicate the location of this pathology, such as a box or a segmentation, SAMA is focusing its attention on the area where the presence of a tree in bud is evident. This can be identified by the yellow color in the picture. For this patient, the clinical information mentions the presence of two pulmonary nodes, one in the left upper lobe and the other in the right lower lobe. Again, SAMA manages to focus its attention on these anatomical locations, even without having annotations of the exact location and shape of the nodule. Here we can see the filter's response for 4 different patients in each column, for coronal, sagittal, and actual view. Additionally, on top of each image are the radiologist's findings. These results emphasize the central idea of our method, to use multimodal information to express spatially the clinical findings provided by the radiologist, enriching the final representation and producing better predictions. So, in conclusion, we present SAMA, a novel method for the multimodal analysis of lung cancer, which formulates this task as visual grounding, building from techniques found at the intersection between vision and natural language. SAMA fuses channels and spatial attention mechanisms, seeking to resemble the diagnostic process of radiologists. This multimodal fusion strategy could be useful in other clinical settings where visual data is complemented by other sources of information. Thanks for your attention. If you have any question or would like to discuss our work, please contact us.